Hello everyone, I'm Ming Shu. I'm an advanced endoscopist at Kaiser West Los Angeles. And
Hi, I'm Jennifer Fan. I'm also an advanced endoscopist from Hoag Digestive Health Institute.
And we are here to talk to you today about the EndoFlip and EsoFlip catheters. I think some of you may be familiar with both systems. They're from Medtronic. And what we have here is the EndoFlip, the classic EndoFlip catheter. And it's essentially a kind of a real-time impedance catheter. It has, depending on the size, there's a couple of different sizes. There's the 8 centimeter and the 16 centimeter, the longer one. But there's somewhere between 8 to 16 of these pressurized sensors along the catheter. And the clinical utility of this is really for essentially giving you a real-time, almost close to manometric measurement of esophageal, and sometimes pyloric, but more demonstrated in esophageal disorder, measurements of pressurization as well as diameter, descensibility of the esophagus. And clinically, where we use this most often is in the setting of esophageal motility disorders, specifically for our patients with achalasia. So classically, we at our center, before we perform a POEM procedure for patients with achalasia, we almost as standard of care do a pre-operative EndoFlip measurement. And the measurements that you're looking for, they are spelled out here, and you can also see the pressurized images here on the screen. But really, it spills out a couple of very important measurements, which is the diameter of the GE junction, which is what we use to measure how tight the lower esophageal sphincter is, as well as the descensibility index, which is the measurement of compliance, kind of the EndoFlip equivalent of what an esophageal manometry would give you in terms of the integrated relaxation pressure. And then lastly, it'll have a pressure measurement as well. So because of the way that the catheter kind of measures pressure, you can kind of see, if I try to mimic someone who has achalasia, I want you to focus kind of on this image of the balloon here. And what you can see is that, for example, if you have someone who has achalasia where the lower esophageal sphincter is extremely tight, you can see that there is a pressurized high pressure zone with where the red and the maroon color is, where the high pressure is. And when you perform a POEM procedure, what you ideally like to see is a significant change from the preoperative measurements here, where the descensibility index is currently measuring at 1.3 to something that is definitely above 3. Generally, we try to shoot above like 3 to 3.5, but we also want to see that the pressurization portion of the catheter is improved. So for example, this would be a much better post-POEM EndoFlip image of what that pressurized system looks like at the LES. And there is some data increasingly to show that EndoFlip can be helpful in guiding kind of in real time when you're doing endoscopic myotomy, how much more extensive myotomy you need to do. I think a lot of people are using it for that purpose. We certainly do, and we will do a pre-operative measurement and then a post-operative measurement to ensure that we did an adequate LES myotomy. And if we see that there's still some high pressure areas, then there's more fibers that we need to cut, or we need to extend the incision further into the gastric cardia to ensure that we get an adequate myotomy. So that's clinically what we use it for most commonly. And then the EsoFlip catheter is, it's not hooked up here, but it's this catheter here. It's essentially like a more stiff version of the EndoFlip. The EndoFlip is really a diagnostic catheter. It's not a therapeutic catheter. The EsoFlip is what we would imagine replaces pneumatic balloons, when we used to have pneumatic balloons. It's a stiff, much stiffer catheter, and it's used for kind of what you would typically use a pneumatic balloon for, which is stricture dilation, more therapeutic purposes. But that is the kind of overview of the EndoFlip and EsoFlip.
Yeah, I think that's a fantastic overview. I think if anyone needed just like a 3 or 5 minute primer of what EndoFlip is and EsoFlip is, this would be the way to go. I would say some other clinical utilities that we're doing it for. So at Hoag, we're a big foregut center, really focusing on reflux. And so part of our reflux workup, especially for those who want any sort of surgical or endoscopic intervention for their reflux, is to do an EndoFlip. Mostly, honestly, to make sure that we're not doing it on an accidental achalasia patient. They may mimic reflux, but it's not truly physiological reflux. We also use it intraoperatively during our combined TIF procedures, or the C-TIF, hiatal hernia repair, with the transoral incisionless fundoplication. So we're using it in real time to actually see how tightly the crura is being cinched, and if it potentially can tell us in the future how well a hydrohernia and a TIF can actually hold up based on intraoperative EndoFlip measurements. So a lot of an expanded usage actively happening for EndoFlip. And I agree, EsoFlip has pretty much replaced any concerns that we had with the pneumatic dilations, because it gives you real-time pressure reads, right? So you're able to not maybe have to go all the way to 35 millimeters of mercury, but you can kind of go somewhere in between where you feel that the blanching is correct and the pressure reading has now effaced itself on the EsoFlip.
Yeah. So I mean, overall, I think the utility of the system is the real-time data that you get. You cannot put somebody through an esophageal manometry in the middle of an intraoperative fundoplication or a poem, and this catheter really does fill that gap of information that's really critical.
So I guess the question that some people ask is, when do you EndoFlip versus when do you go straight to mano?
Yeah, so that's a really good question, and I think different centers have different approaches. We certainly still rely on esophageal manometry, especially because we want to get the peristaltic information about the upper esophageal body, which I think there's not standardized interpretations of what that means on the EndoFlip. That's a really good question. But in patients, for example, with sigmoid esophagus, where you have a failed manometry and the catheter can't make it through the LES, and you really cannot measure an LES measurement, EndoFlip is a perfect solution to that, because it gives you a real LES measurement. It can be endoscopically guided much more easily than a manometry catheter. And the patients, it doesn't matter if the patient can't swallow, is not awake, it's done under sedation. So for the purposes of, failed manometry or incomplete manometric data, I think this really fills a really good gap.
Yeah, I agree.
Yeah,
exactly.